Hi, good morning, everyone. Welcome to our weekly session. We are on 4th of June, and it's 9:30 a.m. Indian Standard Time, and we are meeting from different countries, different places, different region. So good morning, good evening, good night for a lot of people here. We come across with a lot of cases over here with a lot of new subjects. Pandemic is there, pandemic is getting over, pandemic is still coming in, different problems going on. So we have a radiology, a subject today. This is 113th CMAAO International Weekly Meeting. And the topic for the day is role of radiology in COVID-19 management, the challenges faced, the solutions offered, and what we learned from it. To talk about it, we have Dr. Abhishek Bansal. He's a consultant, Department of Radiology, Interventional Radiology from Rajiv Gandhi Cancer Institute of Research Center. He has completed his medical degree from Maulana Azad Medical College and a senior residency program for Army College of Medical Sciences. He has followed with the fellowship in vascular and interventional radiology from Shri Gangaram Hospital. He carries a rich experience in both vascular and non-vascular interventional radiology procedures, which involves the minimum invasive management for various tumor and problems associated to such tumor. He has undergone special training from Georgetown University Medical Center, Washington, D.C., Cleveland, USA. He has also done research elective from Johns Hopkins University, Baltimore. He has more than 15 publications under his name. He has won Young Interventional Radiologist Award. Over to you, Dr. Abhishek.
Thank you so much, Mr. Soyo, and for the kind introduction. And honestly, it's an honor and a pleasure to be talking in front of such elite audience. And today I'll be sharing a perspective from a radiology point of view. And I'm sure that's going to be interesting because you people are the leaders of the medical institutions across the globe. And I'm sure whether radiologists come forward actually to be able to discuss such issues, what we have faced. And this is going to be a slightly different outlook of how we see COVID from a radiologist's eyes. I just share my screen.
Sure, thank you.
So is my screen visible?
Yes.
Okay. So it's an honor to be here today, and good morning, good afternoon, good evening to all of you who have joined from across the globe. Thank you for taking all the time. And I actually bring greetings from my institute, which is the Rajiv Gandhi Cancer Institute and Research Center. It's a 500-bedded hospital in New Delhi, India, that purely deals with the oncology work. But what we realized during COVID-19 was everything from oncology had shut down, and we were all actually doing COVID-19 management only. So this is what this pandemic has taught us. Though we are super specialized oncology setup, but for at least a few months when we were dealing with the COVID peaks, we were doing everything except for oncology. So that's about it. I think that was the biggest challenge that our whole institute faced. And I think not just our institute, hospitals across the globe must have felt the same. So I'll start with the first part of my topic, the challenges that we faced from a radiological perspective. We all know that the severe acute respiratory syndrome coronavirus 2, the SARS-CoV-2 or the COVID-19, I just highlighted the early timelines, how it all happened. On December 2019, it was first reported to the WHO China office. In January, it was declared a public health emergency in China. And similarly, on 30th January itself, the first case in India was reported from Kerala. On 11th March 2020, WHO declared it a pandemic. And 24th March, India declares the first lockdown. So this is how the sequence, just taking you guys back in timeline, how it all happened. And at that point of time, nobody knew what had struck us. And actually, this is just from Mr. Jack Ma from the Alibaba Group, who talked about how to stay alive. He said that and I would actually extrapolate this to not just people in business, to people everywhere, even like struggling with getting managed with COVID-19, or any person who had a family member who was suffering from COVID-19. So he said that for people in business, 2020 is really just a year for staying alive. Don't even talk about your dreams or plans. Just make sure you stay alive. If you can stay alive, then you would have made a profit already. So extrapolate this to just beyond business and in terms of all spheres of your lives. And what we knew was that we just have to, whatever we're going through, we just have to sit it out to make sure that we suffer as minimum losses as possible. And the losses, by losses, I mean in terms of human lives, in terms of decreasing the morbidity of our patients, and whatever best we can do for our patients. We didn't know what had struck us. The scientists were busy studying the coronavirus still. All sorts of publications were coming across. We knew a number of proteins that were on the membrane of the SARS virus, and we knew that studies were coming up that how ACE2 was highly expressed in pulmonary epithelial cells, and that was a major area of attack by the SARS-CoV virus. And ACE2 is actually a functional reservoir for SARS-CoV-2. And this is how it would actually attack the respiratory passages and go further down into the lungs. And majority of the complications, majority of the lives that we lost were mainly because of the pulmonary complications. And that's primarily the main organ where the COVID virus actually hit the human population. And the main challenge was the diversity of the virus. It would just keep on mutating. There were so many mutations, so many proteins that were coming up every day. Every day, I remember reading in the news that this is the new protein, this is the new spike protein, this is what. And actually, from the even scientific community, we didn't know actually what's really the ideal way of managing these COVID-19 viruses. I remember during the first peak, COVID peak, there were guidelines that were getting issued in terms of what would be the ideal management of COVID-19. And every alternate day, or for that matter, every 3-4 days, the guidelines would change. And the drug that we were thinking of as a magic drug would suddenly find no repute in terms of it would just be discarded, that this is not an effective drug for it. This happened with a lot of drugs, even with the plasma therapy. And till date, we don't know that whether it's going to be beneficial or not. There are conflicting data in terms of some papers say that it's very beneficial in advanced in severe cases, but there have been conflicting data that talk about that it may not have any beneficial role in such patients as well. So what really happened at the ground level? We know that the worldwide outbreak disrupted the steady world of healthcare. The vast proportion of healthcare resources were dedicated to handling the pandemic, just like our hospital. Yet there were frequent reports of unknown presentations and complications. There were cases that we didn't know what was happening. Sorry. They were changing usual standards of care and resource allocation in health centers. Every day we're doing it, we're taking it how day by day, how things are happening, and accordingly allocating resources as per the requirements. They were changing guidelines every almost fortnight. The knowledge was still evolving. And what we realized was that the collaboration of multi-speciality clinical teams actually improved patient outcomes. So for the first time, we realized that if the multiple teams going to get together, we would actually get better results. And compared to previous viral pandemics, actually we realized that imaging modalities are now playing an essential role in the diagnosis and management of patients. This was something that was not seen previously, or probably because the last pandemic that we know of was way back in early 20th century. During that time, the Spanish flu and all those pandemics, I think the radiological imaging was not that evolved. We didn't have any ultrasound. Even the X-rays were just had come into the practice, and eventually we didn't know what was happening. So it was just about managing these patients clinically. So now, for the first time, radiology was taking an active part in managing and diagnosing also these patients and actually formulating the further treatment outcomes. There was a tsunami of COVID-19 publications, not just in terms of management, diagnosis, but these are radiological articles. Even the radiological publications were flooded. All radiology journals were flooded with what's the COVID presentations, what are the findings, how to go about it. So we didn't know what really was happening. And this one paper is from the European Journal of Radiology. This is from our institute only. And we had actually given a scoping review that, okay, this is what has been happening, and this is what would be the basic minimum, or this is what we would actually go forward in terms of diagnosing and even prognosticating such patients. So all this was happening all the time. There was a bomb of knowledge all around you, and you didn't know which one to pick up for helping these patients. We specifically in India, when the second peak and when these peaks happened, because of our sheer huge population, a lot of patients had actually a long waiting time for COVID-19 RT-PCR tests as well, and a lot of them were not getting the dedicated attention. So it was a huge demand for a CT scan for the chest, because unfortunately some of the patients had actually started getting the CT scans for the chest themselves to help in diagnosing of COVID-19. And because also the RT-PCR test was taking almost 24 hours for the report to come, so these patients would actually throng the CT scans, the radiology departments for getting CT scans. And during that second peak, we get a news statement from the AIMS director of New Delhi, that's the biggest hospital of our country. He actually rightly warned against going for CT scan in mild COVID cases, but he also touched down upon the point of it may cause more harm than good in terms of the risk for cancer due to radiation. So that actually created a lot of problem in terms of a lot of now, not just we were dealing with COVID-19 patients, but we were actually counseling patients that CT scans will not cause cancers because these are modern day CT scanners, and with such low radiation doses, you are fine. But yes, it should be optimally utilized. Sorry. At the same time, there was a trial going around with the vaccines. The scientists across the globe were actually working hard in terms of to look for a vaccine that would be reliable, and there were trials that were going on simultaneously. Not just that. So this is a very interesting news item because we just didn't know what's happening and what to do about it. So actually, UK government sanctioned thousands of pounds for even getting medicals for dogs who could detect COVID-19. And this was something that was happening during all that time. And imagine this now, and we would be laughing at ourselves that this is what, to this extent, we actually went. And this is how desperate the human race was during that pandemic. These are some pictures from Indian hospitals, and it was a huge lines outside the hospitals. The oxygen supply was coming short, and it was a bad time for all of us, not just for the patients, but for all the healthcare. And these lines that we see outside the hospitals, these were the lines that were actually seen outside the diagnostic centers also. We would see patients waiting in line for getting the chest CT scan done. And it was a huge constraint on not just the overall healthcare, but now the radiological services as well, because a small center who were just catered to probably 25 CTs in a day was now catering to almost 250 CT scans of chest in a day. So imagine the sheer workload that was now suddenly put on these people, not just the radiology technicians, the radiology technologists, the radiology owners, but the radiologists themselves. And all of them were not able to cope up with such a sudden huge workload. We had to do a lot of awareness to reduce the panic. A lot of the news channels were flooded with what COVID-19 was, how to do, how to manage it, and all that. All that was happening simultaneously. And not just to talk about the impact on economy, that was happening simultaneously. So economy would have an indirect effect on healthcare as well. People who were struggling, it would be now difficult for them to even afford the hospital costs, because in our country, in India, the health coverage, the health insurance coverage is still pretty less, and majority of the patients are paying from their own pockets. So any impact on economy is bound to have an impact on hospitals and radiological setups as well. As I told you, there was a limited manpower resources in radiology departments, and they were thronged with what the huge sudden surge of CT scans. The radiology departments were trying their best how to sanitize these scanners after each scan, how the technologists were bearing the brunt, because the technologist was the first person who was actually coming in contact with these COVID-19 positive patients. He was the one who was positioning these patients on the CT scanner. He was the one who was actually holding their hands and doing the scanner. So imagine a single person, or probably 2 or 3 people, donning a PPE kit and getting the patients in and out, and almost doing 200 patients in a single shift. So that was a sheer work pressure these technologists faced during those times. So that was something, and a very commendable job that was being done by the radiological technologists. It was not just scary for the patients, but for the families of healthcare staff as well. This is one news item of mine in Hindi, but that's the national language of India, where I talk about how I was scared in coming in contact with my parents at home. So I actually secluded myself from my parents, and I was living on a different floor in the same house, and we didn't used to come in contact with each other because I was so worried for them. I didn't know what was happening. How infectious was it? What's going to happen to me? At least I thought that at least my parents, who are probably old and senior citizen, at least they would be safe as long as they're not coming in contact with me. So that was all happening all around us. We didn't know what was happening. This is a chart that I'm sharing from my department, and it was actually showing an impact on radiology workload at our hospital. And if you compare April 2019 with April 2020, there was almost a 62% drop in the workload. This was what has happened, because now majority of the patients who were getting admitted in the hospital were the non-oncology patients. And just see, in terms of the CT scans were still okay, but the mammography, the routine breast cancer workup, and the interventional radiological procedures, it's a drastic drop. Almost 90% drop in a routine cancer screening in our breast unit. So that was something that was a sheer a hit back onto the radiology setup, radiology practices. And this is how we had to cope up, not just with the workload, but the decreased workfall as well. So that was all about what we all had faced in terms of the difficulties, the challenges. We didn't know what was happening. But as human race has always been there, for every problem, I think there have been fantastic scientists and people who worked across the globe tirelessly, and we could offer some solutions based on what we learned from these amazing scientists all across the globe. Just briefly forwarding to 2020, what we are in today. The cases are still keep coming and going. So this talks about the last year's the Delta wave in India and the Omicron wave in January, and even now a few isolated cases are coming up. But touch wood, what we have learned, none of these cases are having that severe presentation that we were seeing previously. And total number of cases in India have been somewhere around 4.32 crores and around approximately 5 lakhs deaths. Though this figure is disputed by WHO, but whatever it is, we for sure know that this figure is slightly more. And but even then, even if it is exact figure is 5 lakhs, it's no small number. And to imagine so many deaths, and I think everybody lost someone from their own families, and it was something that was unprecedented and unthought for. So that was something that has hit us so bad. And in terms of what really changed the pandemic course was the vaccination. And even now, I think it's going very fast across the globe. And at least in India, almost 65% of the population is fully vaccinated. And this is the worldwide data that talked about 60% of the patients who are fully vaccinated. Sorry. So this is what has really changed and has broken the backbone of COVID-19 pandemic across the globe. In terms of how radiology helped in diagnosing and management of COVID-19, we had different modalities ranging from a small basic X-ray, a CT scan, ultrasound, MRI, and PET-CT, which is more advanced. And X-ray was the first modality. So every patient who would have some sort of breathing difficulty, respiratory distress, or symptoms of COVID-19 pneumonia would actually undergo a chest X-ray. It is a bedside available, very easily accessible. We had a lot of portable X-rays in our hospital, which were like working all throughout the day, 24 hours, almost non-stop. And all these patients were, these portable X-rays were being shifted to the COVID wards, the COVID ICUs, where these patients would not be needed to be shifted to the radiology departments, and the X-rays would be done bedside. And it was useful in serial monitoring as well, because if the patient would worsen, the pneumonia level would worsen on the X-ray, you could identify it early and then take the definitive measures as per the X-ray findings. The CT has been the workhorse, and I think what COVID-19 has done is it has really highlighted the importance of CT, not just with the radiologists, but amongst all clinicians and even the general public. And so much so now, with so many algorithms coming up, the AI that is coming up big way, I think CT is something that would probably in the future times to come be more like a useful like a X-ray in terms of it has to be so easily accessible that because the way it has changed how COVID-19 was managed, how it saved lives during COVID-19 by telling us early features, by telling us worse prognostic features, so that these patients could be managed early. So that's how CT has played a wonderful role In terms of acute presentation, we knew that it has ground glass opacities that could be unilateral or bilateral. In case of progressive cases, we saw huge, large, confluent, multifocal consolidation, ground glass opacities, diffuse consolidations. And when the patients were on a phase of recovery, there was a gradual progressive resolution, disappearance of signs, and then we could actually breathe lightly, okay, that this patient is going towards a recovery phase. Ultrasound was again something that was very useful in terms of bedside evaluation of pleural effusion, because a lot of these patients had a lot of effusion, and these patients were actually requiring a lot of drainages as well. And it was a non-invasive modality, no radiation involved, and was very useful. MRI was less useful, was more time consuming, but yes, in certain cases, it was a problem solving tool, similar to the PET CT. Excuse me. As I told you, CT was a workhorse. And with CT, a lot of artificial intelligence imaging is coming up these days. And I've taken this from a research paper that talked about how CT, if you can see these three images, these are sequential scans. And if you would see in the periphery, these are some ground glassing opacities. These white patches, this is what we call as ground glassing opacities. So gradually, these are decreasing. So once during treatment of this patient, if you would get a CT picture like this in between, you would be reassured that, okay, this patient is getting fine, and I think the treatment is going on the right lines, and I can continue on this treatment only. However, if these patches were increasing, you would know that, okay, this patient is not responding, and maybe I need to escalate the management, maybe I need to add further steroids, maybe I need to add immunomodulators. So that is how the CT was a game changer for these patients. And in terms of a lot of CT scoring indices came forward, we had a CT scoring as well that would actually quantify also how severe the infection was. And using these artificial intelligence, we can actually mark these patches, give a volumetric rendering to these patients, and actually tell the clinician as well, okay, this is what this patient is dealing with, and this is how you need to manage now. So that was all about how CT was helping these clinicians in managing COVID-19 patients. The typical CT findings in COVID-19 was, peripherally distributed multifocal ground glass opacities with lower lobe predilection. So majority of these patients had ground glass opacities, as I've already told, and that too in the lower lobes. However, whenever there was a disease progression, these ground glass opacities had increasing numbers, extent, and density of these opacities. And what was important was that we needed to have a thin chest CT, because that was the one that played a major vital role. If we didn't have these thin slice CTs, you would have thick slices. Then again, there would be a problem in terms of definitive scoring for these patients. So these are the typical findings, and this is what we were actually looking for and giving the CT scoring index on the basis of these findings. Being an oncology center as ours, we had a lot of patients who were already undergoing cancer treatment. And this is a 52-year-old gentleman with carcinoma urinary bladder who had already gone a radical cystoprostatectomy. And now he had presented to the hospital with sudden increase in breathing difficulty. And he was admitted and undergone a chest CT, chest X-ray initially, which was not that remarkable in terms of any problems, but we can see some haziness in bilateral lower zones. And when he undergot a CT scan, so we saw these ground glass opacities in both lower lobes and also in the right middle lobe. So what was important was now we had to differentiate between two things, whether it was COVID-19 or whether it was disease progression due to cancer. But this patient had straightforward ground glassing opacities, so we were fine in terms of diagnosing this patient as COVID-19 and initiating the treatment for COVID-19 for this patient eventually, and he got fine. Now comes the hematological patients. Now, we all know how these patients are susceptible to a lot of infectious diseases. Either ways, they would be suffering from fungal, bacterial, viral pneumonias, and COVID-19 really changed how these patients were actually getting treated, because now all of them would show ground glassing, and it was difficult for us to really ascertain whether this was purely COVID-19 or it was something else. But yes, as the medical dictum says that in terms of when we are having a pandemic, so think of it as COVID-19 unless proved otherwise. So this is how the difficulty arose in terms of managing cancer patients, and specifically the hematological patients who were actually prone to a lot of infections already. So again, this patient of AML, came with sudden breathing difficulty. And this is how its CT chest looked like, a lot of ground glassing on both lower zones. And this was quite severe actually. And he had a prolonged ICU stay, but eventually came out and was managed fine. So, but again, yes, timely intervention, timely diagnosis was crucial to managing such patients. Another complication was pulmonary embolism. So we all knew how pulmonary embolism had led to sudden deaths in all these COVID patients. And this is one CT angiogram that showed how a pulmonary embolus was actually seen in the left pulmonary artery. And this was actually a drastic complication of COVID-19. And we would actually institute not just mechanical pulmonary thrombectomy or thrombolysis, but even a systemic thrombolysis for patients who were not candidates for pulmonary or mechanical thrombectomy. So that was something how CT played again an important role in managing these patients. Because so much was happening, so we need to have a consensus statement. Because as I told you, people were thronging to CT scanners, the diagnostic centers. So we were lucky that we got a consensus statement from the Fleshner Society. It's a very prestigious society that talks about how pulmonary nodules should be followed up. And in terms of one scenario, it talked about was that we need to have a pre-test probability of COVID-19, and provided there are no significant resource constraints, then it gave a very informative chart in terms of how COVID-19 patients should be followed. If the test is positive and it is a moderate to high pre-test probability, and there are risk factors for disease progression, that is where the imaging is indicated. Okay, so we should not be going for a imaging for a mild case with a low pre-test probability. And once imaging is indicated, we have to monitor for worsening of respiratory symptoms. And if there is worsening, again, imaging is indicated. So it is very clear in terms of when is the imaging that should be indicated. Whenever a pre-test probability is high, there are risk factors for disease progression, and there is worsening of respiratory status. However, when there are no risk factors for disease progression, imaging may not be indicated. However, if we have to ask these patients to monitor for worsening of respiratory status, and if there is worsening of respiratory status, then again imaging is indicated. Finally, imaging is not indicated in patients who have a low test pre-probability, but again, you have to monitor these patients continuously. And whenever you see any signs of worsening respiratory symptoms, imaging does play a role. And what is important is that we should not wait much, because early treatment plays a key role. So if you can diagnose these patients early, provided they have a moderate to high pre-test probability and they have a worsening respiratory symptoms, that is where the imaging is indicated and should be used optimally. As I talked about already, artificial intelligence, it is coming a big way in all radiological applications, and even COVID-19 was untouched by AI. So this paper actually talks about how COVID-19 diagnosis was actually made on chest X-rays and a multi-reader evaluation of an AI system. And this actually heat map, this paper, he generated heat maps on chest X-ray. And this was a 74-year-old gentleman with positive RT-PCR test. And the AI system's heat map score is 99.8. Is actually covering up the whole of the pulmonary, both lung fields. And this is one patient, considering his age, his other comorbidities, he's at a high risk of developing complications due to COVID-19. So on such a chest X-ray, your threshold of further investigation should be further low. This patient should be immediately admitted and undergoing a further CT scan for baseline documentation and then further treatment subsequently. Coming on to the interventional radiological procedures, I'm an interventional radiologist by profession, so this is something that's pretty close to my heart. And our work didn't stop. As I showed you previous slide, the diagnostic work still dropped to almost 90%. But the IR work was still, it dropped. We were not doing the routine chemoemulations for HCC. We were not doing biliary drainages for CAGB or cholangiocarcinoma. But we had actually put in a lot of effort for managing these COVID patients. And I'll come back to this slide, but I'll just show you this one small slide in terms of what was a COVID-19 complication and what we could offer for these patients. So for COVID-19 patients who had renal disease, we were actually now called in to place venous dialysis catheters through which we can perform dialysis. We were placing peritoneal catheter dialysis, nephrostomy. A lot of these patients who had urinary obstructions or urinary calculi, because the anesthesia department, the OT department was overthronged. The anesthetists were not available. So now the stress was on minimally invasive procedures such as PCNs by IR people. So that was what we were doing. In terms of managing these renal complications, even renal biopsies was being done by IR people to diagnose the complications. For any thromboembolic disease, I showed you a case of pulmonary embolism. IVC filters were being placed. I talked about how catheter was placed right into the pulmonary artery and a catheter-directed thrombolysis was done. Pulmonary thrombectomy was also being done. And a lot of these patients would have deranged coagulation, and strangely, we saw a lot of these patients having bleedings in the pelvis regions, and mainly in the inferior epigastric artery, in the abdominal wall, in the rectus sheath. A lot of these patients were having hematomas in the rectus sheath. So we were actually doing angiography and embolizations for these patients, and these patients were actually getting treated well. Strangely, for the first time in my career, I got a reference for percutaneous jejunostomy as well. That was during COVID-19 peak, because now the anesthesia department was overwhelmed. They were not available. The surgeons were not available. The oxygen was not available. So for an active procedure like feeding, for a surgical jejunostomy, now to open up the whole OT, to open up the whole oxygen, oxygen that is very critical. India was short of oxygen supply. There was a problem. So now we started getting references for percutaneous jejunostomy as well. So we were doing a lot of patients with percutaneous jejunostomies under local anesthesia without any requirement for oxygen supply. A lot of these patients had pleural effusion, is aspiration for continuously. That was the extent of complication of these patients. A lot of these patients had abscesses. We were doing those abscesses. Again, patients who had cholecystitis, now they were not undergoing cholecystectomy, and we were doing percutaneous cholecystostomy for these patients. Again, that was something, the extent of workload that we were doing. So we stopped doing the traditional work that we were doing, but we were doing something that was helping these patients now a lot. In terms of specifically at our hospital, we had a lot of patients of pancreatitis as well. We had a patient of cholangitis as well, so we did a PTBD for that. We did NG tube insertions. Venous access was very important. A lot of these patients would stay in the ICU for a long time, and we know that central line would not be useful for beyond 7 to 10 days. So we were placing PICC lines for these patients and giving venous access for these patients. That was something very, very, very critical for these patients. So what changed at our hospital apart from this? So this is our hospital. So now there was dedicated COVID screening clinic outside the hospital before we could enter the hospital. All patients, their attendance was screened for COVID-19. Our radiology department took all the precautions, and this is our CT scanner. Our nursing staff and our technicians were all wearing full PPE kits. The sheets were changed after every scan. The entire CT gantry, the CT scanner room was sanitized. And this is me and my nursing staff. The procedures, this is how we were doing the procedures. And this is our interventional oncology cath lab, and this is how we're taking all precautions and doing the procedures. That was something that had changed at our hospital, and we were not used to it previously. In terms of radiology specific pre and post COVID era comparison, prior to that, the diagnostic radiology work timings were from 9 to 5:30 routinely, barring the emergencies. And during COVID peaks, we had staggered timings. We had 2 teams, all of us were wearing PPE. The 2 teams were working on alternate days, so that in case any one team gets COVID positive, at least the other team is there in the hospital to continue with the work. We were sanitizing after each examination. There was minimal handling of the patient. A COVID test was done before any IR procedure, and a lot of radiologists were offered the option of working from home as well. This is our the reporting room, and this is how the COVID has changed how the radiology reporting has been done. Previously, the people would sit together for common reporting, and now there's a lot of gap between different workstations. And I think this is going to stay with us, and this is how COVID has changed our lives in terms of how the radiology department functions. The physical academic meetings were absolute no, and social distancing taught us how we were introduced to the world of webinars, and this is one of the webinars that we are attending today. That was something pretty new to us, but yes, I think this is going to stay with us, and this is actually brought us all of us across the globe together and much closer than what it was previously. In terms of India initiative, in terms of how India managed, there was an Arogya Setu app and a lot of awareness that helped in controlling the COVID-19 infection in India. So coming on to the final part of my talk, what we really learned from all this. We have seen what were the challenges. We have seen how we offered these solutions and what all we did for these patients. So what we learned was that we cannot take COVID-19 peak lightly yet. Even now, we are having isolated infection outbreaks. Luckily, they are mild, but still we can't be like too casual about it. So we have to be ready for the next variant, the peak or the pandemic. What is very important is that a lot of radiological infrastructure has already been upgraded. Now we just have to maintain that infrastructure. We cannot just let it be. Radiology, as I told you, radiology services play an important role in the multidisciplinary management of COVID-19 or other pandemics that may strike the human race. So it has taught us that radiology is very important. A lot of existing hospitals didn't have radiological services. Even talking about New Delhi, that's the national capital of India, a lot of even the state government hospitals didn't have existing radiology setups like a CT scanner or MRI scanner. So that has changed after COVID-19. And now majority of the hospitals have their own CT scanners, own MRI scanners, and they have integrated radiology as a part of their routine clinical work. What is important is that we maintain this upgraded infrastructure so that in case any further peak happens, we are ready for it. We have to create adequate training opportunities because training the manpower in healthcare is very important, and telemedicine is something that is going to stay with us. A lot of you, the doctors across the globe, now were exposed to how patients were contacting us through WhatsApp, through phone, which may not be ideal. Okay, but yes, we have to move on with times. The online consultations are going to stay, and at least for patient follow-ups, I think online consultation will stay. The virus, what we have learned is that the virus doesn't respect geographical boundaries, race, or wealth. The only way forward is that we continue with the vaccination drive to cover the entire world, and we invest in healthcare suitably. A lot of countries invest very poorly with their healthcare. Even in India, our GDP expenditure in terms of investment in healthcare is pretty low. So I think that's something all of us have realized. And even in healthcare, the investment in radiology should be ideal. Gone are those times when we could just do with a chest X-ray and ultrasound. I think all these hospitals, which are adequate sized hospitals, would have full-fledged radiology departments now. So I've talked about when should the imaging be done in COVID-19. We have learned that chest imaging should be used cautiously. It is not indicated in suspected COVID-19 and mild clinical features unless they are at risk for disease progression. It is indicated in COVID-19 patients with worsening symptoms, and in a resource-constrained environment, maybe like India, it is indicated for medical triage of patients with suspected COVID-19 who present with moderate to severe clinical features. So this is again a consensus statement from Fleshner Society, and I think this is what is the gist of my talk in terms of if something, another peak or another wave comes. So this is how we're going to actually be following these guidelines rather than subjecting all patients to CT scanners. This is what should be the way forward. I have to thank my department chair, Dr. Arvind Chaturvedi, from whom I've borrowed some of the slides liberally, and who has been guiding us, our department and our hospital, in managing this COVID pandemic. This is the story of a virus. WHO has declared a pandemic. The human race is determined to find an answer to not just this pandemic, but for future ones to come. It's a question mark. It's for all of us to answer. And I think we have found an answer to this one. And I'm sure our race will continue to fight for any future pandemics as well, especially with monkeypox also now coming up. We're not sure what's going to happen. But yes, COVID has taught us a lot of things, COVID appropriate behavior. I think that should stay with us and should guide us in times to come. Thank you for participating and stay safe. This is my team, how we're working with COVID PP kits. And I'm open to any suggestions, any comments, anything that you would want to ask. And in case you want to contact me afterwards also, so these are my details given below. Thank you so much.
Thank you so much, Abhishek. It was very nice presentation. We will now open the floor for question answers. I'm sure there are a lot of question answers over here. So Yes, Dr. Muzakwa from South Africa, please go ahead with your question.
Thank you so much for this extensive presentation, and thank you so much for taking your time to present to this platform. And just on my side, I just want your take, colleagues. I just want your take on the issue of equitable access to these radiological services. How did it affect India and the whole globe? If you can just give us an indication, how did it affect the equitable access? Because I think one of the problems that we're facing is access of access to these services by mostly urban populations, and they'll find that those that are in a rural area setting, or may not have equitable access. Was there any challenge that you saw at that time? Thank you.
Thank you, Dr. Zukwa. That was a fantastic comment and a fantastic question. Actually, we all suffered at hands of COVID-19, and that was a big challenge that our country suffered as well, country faced as well. Definitely, the rural areas have poor penetration of healthcare facilities, and not just the healthcare facilities, the diagnostic radiological facilities as well. So yes, there was slightly a poor equitable distribution in terms of what the rural people faced and then what the urban people faced. But yes, that's what the COVID peak taught us. And as I told you, a lot of hospitals previously in even the capital of India, we are in New Delhi, didn't have dedicated CT scanners, didn't have dedicated MRI setups. So now after that, we have learned. So a lot of these hospitals have now started putting up dedicated radiology departments. And this is what we have learned, that radiology is now playing an integral part of all these pandemics. So without radiology, it gets difficult to prognosticate, to diagnose these patients. So I think it's going to stay with us, and that highlights how managing COVID-19 is definitely a one part of it, but to diagnose it is equally important. And not just the laboratory facilities that need to be upgraded. The radiology infrastructure should also be upgraded, and that's what it taught us. We definitely face some challenges, but yes, we learned from it, and we're working very hard towards it. A lot of centers across India are now investing in radiological facilities, and it's coming up big way, and it's going to stay. And you highlighted the importance actually. Thank you so much.
Dr. Sajjad from Pakistan.
Okay, thank you very much, Sora. Thank you very much, Abhishek Bachchan of Bansan. But you look like a Bachchan. On a lighter mood, I am a ENT surgeon, Abhishek, and you have presented very informative presentation. I must appreciate you. In a lighter mood again, I would like to say that you are suffering from rhinopharyngitis, and please do come to Karachi, because I'm in Karachi. I just want to visit you and advise some medicine.
Sure.
Okay. Thank you again. I joined a little bit late. I heard that you said that the radiology can diagnose as well as therapeutic, diagnostic as well as therapeutic. I would like to know where we can use radiology as a therapeutic regard, particularly in COVID-19. Number one. Number two is in Pakistan, what we saw that the majority of clinicians are advising people to go for the CT scan instead of advising X-ray chest in the beginning, even with a mild symptoms. So you are absolutely right that India and Pakistan people are having a very low income salary, and they are very much worried about their expenditures and worried for their treatment for a pity matter also. So this is very difficult for them to go for a CT scan, which is not available in the public sector hospital everywhere. So in this situation, people are depending on the CT scan to diagnose as early as possible. Secondly, can you say that anything diagnosed through paranasal sinus X-ray or CT scan in COVID-19 during your practice? Thank you very much, Abhishek.
Thank you so much, sir, for the wonderful questions. And I will definitely keep that in mind. And I would want to visit Karachi for sure. I'll visit you, pay your visit for sure. Looking forward to that soon, sir. To answer your first question, sir, as a radiologist, definitely the diagnostic part was covered by us, but the therapeutic part in terms of was not directly linked to COVID-19 management, but the complications that arose from it. I showed a slide where we were actually doing a lot of pleural fluid aspirations, the pericardiocentesis, and even the pulmonary embolism management for these patients. We did a lot of catheter-directed thrombolysis, mechanical thrombectomy for these patients. Apart from that, a lot of small surgical procedures like PCNs, the nephrostomies, the cholecystostomies, and even jejunostomies that were traditionally being done in OTs with the anesthesia backup, with a lot of oxygen supply. I think the biggest problem during COVID peaks was to have a dedicated oxygen supply to these hospitals, because almost always, at least in the Delta wave, we realized that the hospital was on a very thin line in terms of what the oxygen supply was present, and all elective surgeries were actually postponed now because we didn't want the anesthesia department or the oxygen to be actually wasted on any elective procedure. So all these procedures actually came to IR under local anesthesia, because now the manpower, we required less manpower. The anesthesia setup was not required. So this was something that we were playing a supportive role in managing these patients. And one of the most common complications that these patients had was bleeding. So many of these patients, in our experience, I saw at least 10 cases who had bled into the rectus sheath or into the pelvis. And almost all of them had bleeding from the inferior epigastric artery for some strange reason. We don't know that yet, why it happened. But again, that's a very simple procedure. These patients, because you would know, would keep on bleeding. They would be on anticoagulation because of COVID-19. You don't want them to have a arterial thrombosis. And now you're stuck. How to manage these patients? So we did embolizations for such patients. We placed IVC filter for such patients where these patients had DVT to prevent any further pulmonary embolism. So this was more or less the therapeutic part of the gamut of what we could offer our clinical colleagues in terms of managing these patients. Second question of you was, so did I answer your first question?
Paranasal sinus.
Yeah, no. So that was also, so yes, coming to the second question. So you very rightly highlighted the importance of unnecessary CT scans getting done for these patients. And I showed a guidelines from Fleshner Society. That's a worldwide guidelines for even pulmonary nodules follow-up. So this society has given a guideline that you have to look for pre-test probability, whether the patient has a low or a high risk probability. And only when the symptoms are moderate to severe, at that time only a CT chest is indicated, or when a patient is having worsening of respiratory symptoms. So just at the beginning of any COVID-19 infection with mild symptoms, with a low pre-test probability, a CT chest is not indicated. So that is very clear. And somehow there was a misconception initially that people thought that CT could replace a COVID-19 RT-PCR test. No, it's not that. So again, yes, CT is indicated, but yes, it should be optimally utilized, because unnecessarily it would just, if the whole population gets their own CT scan done, I'm sure none of the radiology centers would be able to cope up with that. And forget equitable distribution. Even the biggest urban places, they would not be able to cope up with that. So that is very clear. Third, about the paranasal sinuses, a lot of these patients had sinusitis side by side. So as such, it is difficult for radiology in terms of evaluation, in terms of an X-ray PNS or a PNS to tell you basically whether it's a COVID-19 related sinusitis or not. Yes, there are certain features like what we see in viral sinusitis. There would be less dense contents in a sinus. It would be more of fluids. But yes, as a radiologist, I would not be able to tell you that, okay, Dr. Sajjad, this is a patient who's having a COVID-19 sinusitis. I can only tell you whether this is an acute or a chronic sinusitis. That's about it.
Okay, one thing more I have just remind that people are having during COVID, they are having multiple CT scans by advised by the doctors or by themselves. I mean, self-medication you can call. They go for the CT scan now. I am fit, my lungs is clear, not. Do you think the multiple CT scan for a shorter period during COVID, did you have any complications of having multiple CT scans?
So no, sir. So I would just want to clarify a certain thing regarding that. So yes, CT scans involve X-rays, which are a source of invasive radiation. But I would want to highlight that the modern day CT scanners are so optimally built that the radiation actually is very trivial. Whenever we talk about any side effects from radiation, there are two types of side effects: stochastic and non-stochastic effects. So the long-term effects that we're thinking about from CT scan radiation are probably going to see in probably years to come. But even then, what we have learned from our practice so far now, in a chest CT scan, the radiation dose that is given to a patient varies somewhere from 2 to 3 milli. And if you give a contrast scan, it's 10 millisieverts. So majority of the CT scans were a high resolution CT scan, the HRCT, which was a non-contrast CT, and it was somewhere around 3 millisieverts only. So that's actually the background radiation that a person receives from the space in a single year. So as such, we don't anticipate any side effects in these patients. But yes, it's an open question. We need to follow up these patients eventually, what's going to happen. But to be honest, as a radiologist, as someone who's been practicing in this field, we are not very much worried. But yes, that doesn't mean that we get CT scan unnecessarily done as well. We have to benefit, we have to weigh the risk-benefit ratio. And as a radiologist, we have a principle, ALARA, as low as reasonably achievable. That's a principle that all radiologists across the globe follow. It means that the radiation dose should be as low as reasonably achievable. So that tells me that I have to reduce the CT dose to as low as possible so that the patient is not exposed to much. So that, seeing that principle in mind, yes, we should not get unnecessary CT scan done. But yes, people who have got it done, they should not be much worried about it. So just don't worry about it. I think they should avoid getting a frequent CT scan in the future. That's what my advice would be to them.
Thank you very much, Abhishek. Thank you.
Thank you, sir.
Thank you so much, Dr. Chong, Singapore, our chair.
Thank you, Dr. Abhishek Bansal, for your lovely presentation. Very, very useful to recap the pandemic from the beginning till present. And enjoy your little thing about radiation doses. Yes, we do. Myself, I do discuss quite a bit about radiation doses whenever I do whether I want to prescribe a CT scan for a patient. I actually talk to them about that. And of course, ages and so on matter. Now, I just want to ask you, because on our side, we actually have a radiology suite in our practice. And we've done about 20 patients post-COVID. These will be patients 4 to 6 weeks after their COVID infection. And we did CT lungs, and we found a lot of patches in especially the lower lobes and the dependent areas of the lung. So this is obviously some kind of long COVID, and the treatment really, there's nothing much to do. The respiratory physicians say just let the patients recover. But in your experience at your center, do you use radiology for any kind of long COVID? I mean, have you found anything interesting with regards to long COVID and radiology? Thank you.
Oh, thank you, Dr. Chong. That's a very interesting observation, and actually that's what we have been finding as well. For patients who have been suffering from long COVID and who haven't got all right in terms of who keep having respiratory symptoms, we have found these patches to persist. And not just these patches, a lot of these patients would have long-term fibrotic strands as well, fibrosis as well. So that is where we have been seeing changes gradually evolving from a GGO to a consolidation to probably persisting as a GGO, and then eventually a fibrotic band. But even then, there have been certain amount of interstitial thickening as well, some nodules as well. So we are still learning in terms of how COVID-19 is evolving. And yes, as long as the patient is doing clinically okay, we're really not much worried about the radiological findings, and we tell them that maybe these are long-term sequelae and gradually they have to go back. And again, we leave the decision back to respiratory teams, that the respiratory physician only decides whether the steroid course should be continued further or should be stopped, because again, it would have its own side effects.
Yes. Thank you. You've answered my question brilliantly. Thank you.
Thank you, Dr. Chong.
Thank you, Dr. Martinda Pillai from India.
Thank you. It's an excellent presentation by Dr. Bansal and the evolution of COVID protocol, particularly the radiological investigation part of it. The description that has been given now is mainly during the period of Delta wave, where severe pulmonary involvement has been there. But now, with Omicron, which is supposed to involve the upper respiratory passage mainly, what is the CT appearance? Have there been any case where CT test has to be done in those cases? That's one question. Yeah. Second is, of course, pulmonary fibrosis. What is the percentage of pulmonary fibrosis in the cases where you have done CT scan of chest? And what is the correlation of the CT finding, pulmonary finding, and the clinical picture of the patient? The severity that is obvious in the CT scan, is there a proportionate involvement of the pulmonary function in these patients?
Thank you, Dr. Pillai, for the wonderful questions. Yes, in our experience, whenever the CT findings have always positively correlated with the clinical findings as well. So as I told you, we have a CT scoring index. So as the scoring index gets worsened, sorry, these patients do behave clinically bad as well. So that's been our experience in terms of whether it's an acute or a chronic disease as well. In terms of Omicron infections, to be honest, as I told you, now with Omicron, the guidelines were in place already. So you're not testing these patients, these milder variants for with CT scans. But yes, patients who had severe symptoms, moderate symptoms, were getting a CT scan done, and the long-lasting opacities were still there. So yes, the imaging findings were less severe in terms of what we saw in Delta, but findings were similar. And also with imaging guidelines in place, we were not imaging the people who were generally with milder forms of infection like the Omicron. So majority, 99% of the population was not screened or investigated by a CT with the Omicron wave. And in terms of pulmonary fibrosis, yes, long-term people who had a bad COVID-19 in terms of a long sequelae, a long stay in the hospital, and a lot of breathing difficulties. So in our experience, we have seen those patients, they have not done very well in terms of regaining back their respiratory functions in terms of the routine work that they were doing initially. Now it's much reduced. And yes, in our experience, we have seen at least, I do not have the exact percentage with me in terms of what percentage we have seen fibrosis, but any patient who had a bad CT score beyond 20, we have seen a lot of fibrotic bands in those patients. And I think in my experience, I would not be wrong in telling you that it was saying approximately 10 to 20% of these patients, we have definitely seen fibrotic bands in such patients.
Thank you. Thank you.
Thank you.
Thank you so much, Dr. Pillai. I don't see any more hands. Do we have more questions over here? Okay, Abhishek, I have one question over here. I think we all know Dr. KK used to work on a concept of least medical testing and the lowest cost of treatment. There was something known as CRP value, which he used to determine the first instance of doing the testing. So if that value is higher, then he would recommend further testing. So is there any pre-parameters you look, let's say CT value for the RT-PCR test or CRP values, and then determine whether you need to get the CT scan done and other, like, in terms of condition of the patient, and do you advise, like, yes, CT scan should be done because obviously the radiations are there which are exposed towards the patient? Or are there any parameters you look into it before you consider going for a CT scan?
Yes, so as I showed you that graph from the Fletcher Society guidelines, So we don't see the CRP or other clinical parameters in other biochemical parameters in terms of advising a CT scan. So it's about the respiratory symptoms, the mild, the moderate, or the severe variety. So in case a patient is having a severe symptoms, breathing difficulty, and is requiring oxygen, so those are the patients that I would be okay with in terms of these are the patients who would have a moderate to high pretest probability. And again, as long as the symptoms are not worsening, I would kind of stop myself from advising a CT. Maybe a chest X-ray would do. But yes, once I see the symptoms are worsening, the patient has a moderate to high pretest probability. So those are the patients that I would be advising a CT scan for. But yes, even the practice in India has been more like, as a radiologist, we are not the ones who advise a CT scan. It always comes from the clinicians or the pulmonary physicians. But yes, we do play a role in terms of talking to our physicians, talking to our clinicians, that, okay, this is what, here is a case where CT may not be indicated. So you maybe need to tell the patient that maybe a chest X-ray would just be fine. So we talk to the clinician back rather than talking to the patient directly, and maybe advise them accordingly. But yes, we don't look at CRP per se in terms of whether we should be going ahead. But yes, if D dimer is very high and the patient is at a high risk of pulmonary embolism, then I would not just advise a normal HRCT. I would want to get a contrast CT done to look for pulmonary embolism. So those are some of the factors that I would actually study before at least choosing out what CT study should I be doing.
Thank you.
Dr. Abhishek.
Dr. Chaudhary from Bangladesh.
Just thank you so much. Just two questions only. One thing is that there was controversy or there is not consensus regarding the magnitude of radiation and the comparison of radiation between the X-ray and the CT. So can you just tell me that? And whether it is needed to see the progression by the symptoms you can see. So is it necessary to go for further CT?
So,
okay. Thank you.
So thank you, Dr. Jamaluddin, for fantastic questions. Yes, as I told you, the CT scanners are pretty well built with a lot of radiation protection software and techniques. But yes, in terms of whenever you want to compare a chest X-ray with a CT scan, the X-ray is of very small radiation dosage. In a very crude terms, if I were to compare a chest X-ray between a CT scan, a chest CT scan would actually be having somewhere around 300 to 500 X-rays combined radiation dosage. But yes, as I told you, a modern day CT scanner with a fast non-contrast CT scan would have radiation dose somewhere between 1 to 3 millisieverts. That would be what a normal human being would get from space in a single year. So agreed, the radiation dose is there, but it is not worrisome. But yes, we need to be careful. So unnecessarily CT scan should not be done. So that was a message that Dr. Guleria also sent. But yes, we don't need to panic really that the patients will start having cancer because of CT scan. That is generally we haven't seen till now in terms of that may happen when a patient has been getting a CT scan pretty often. And not just that, for all oncology patients, these patients get a repeated PET CT scan during their entire course of treatment. So we need to balance the risk and the benefit in terms of what we're looking at. In terms of what you rightly said, if a patient is already having moderate to severe symptoms, do we need a CT scan? So there have been conflicting again opinions about it. In terms of CT scan, I personally feel would add on to the knowledge in terms of how much the severity is, and it would actually give the confidence to the clinician. Okay, here is I have a patient who has moderate to severe symptoms, and CT scan is now showing a severity index of 22, 24. The lungs are bad. There is a diffuse consolidation. Okay, there is effusion. So that can actually guide the treatment. So if there's gross effusion, you would be okay with ordering an aspiration of the pleural fluid. If there would be pericardial effusion, you would be okay with aspirating of pericardial fluid. And in case you feel that there's a collapse of lung, that you would not be able to see clinically, okay? Because once this patient has a consolidation, even on clinical auscultation, you would just hear absence of breath sounds. You would not know whether it's a collapse or a consolidation. So that would change the difference. So in case there's a mucus plug that is stuck in the bronchus, then you can ask your pulmonologist to actually go in and take that plug out. It would add on to a lot of information, but yes, it has to be balanced in terms of which are the patients who actually need it and which are the patients in whom it would be indicated. And actually, if I can request, if I'm allowed to actually request my department chair, Dr. Arvind Chaturvedi, he's online as well. If he can add on to anything in terms of what I've said. Is Dr. Chaturvedi here?
Chaturvedi, are you there? Please unmute yourself. Welcome.
Yes, can I be heard?
Yes, we can hear you.
Okay, great. So I think Dr. Abhishek has done a wonderful job about the whole topic. And as far as radiation is concerned, we can't say that there is no radiation whatsoever. There is radiation. There is radiation in an X-ray and there is radiation in a CT scan as well. But the CT scan radiation is many, many times more than the radiation from the X-ray. But even the CT scan radiation is in fact much less than what is known as the background radiation from the cosmic world from outside. Whatever radiation you get in 1 year is about 3 millisievert, and the dosage for all these, even HRCT is usually higher than a low dose CT, is less than 3 millisievert. So to that extent, the radiation is a part of life. You're getting radiation anyway, whether you get a CT scan done or you don't get one done, because the cosmic radiation is not scaring anybody or any creature in the world whatsoever. The second part is the risk about the radiation causing cancer. So there has been actually a lot of debate about radiation causing cancer. And what I want to highlight, the controversy, I want to highlight what kind of controversy is it. We have all believed all along that any amount of radiation is harmful. Now that is something which is being challenged today. Any amount of radiation is harmful, and the more the radiation, the more harm there is going to be, is challenged. And it is challenged by a new theory, by a theory that there is a threshold limit. And up to the threshold limit, there is no harm whatsoever. Your body tissues have the capacity to repair. Even if it causes a damage to these cells, they will repair automatically, because if it is only to that extent. And that is also, if I remember correctly, that's around 50 millisieverts. So up to that much radiation, the body tissues in the human being have the capacity to repair the damage done by that radiation. Not only that, the theory further suggests that small amounts of radiation are actually going to be useful. This is very paradoxical, but I'm talking about a no threshold theory. Earlier, there was no threshold theory. Now there is a threshold theory that up to a threshold, the radiation might be useful. Now you would wonder, how can it be useful? Well, on the same analogy as a vaccination is useful, you give live vaccinations to create immunity. So some degree of radiation actually damages the cells and they repair, and there's some kind of immunity which actually takes care of even higher doses of radiation. So this is a new theory about radiation, but only up to 50 millisievert and not beyond. So I think I have answered that question, that this is under dispute. The amount of radiation which is caused by sporadic radiological procedures. I'm not talking about serial radiological procedures or the dosage which are subjected for cancer therapy, which is radiation by radiotherapy machines like linear accelerators and cobalts, etc. That radiation is far higher. So I'm not at all talking about that. I'm only talking about the radiation which is given sporadically for one time or two time diagnostic purposes to a patient by a CT scan or by an X-ray or one of these modalities. And that radiation, the theory is now, it has yet to be proven actually, but there is a lot of debate on this, that it might do some good. So this is paradoxical to what we have believed so far. Anything up to 50 millisievert is actually training your tissues to get used to some radiation and repair, just on the same analogy as a vaccine works. You give small dose of the same virus and then or attenuated virus, and the body reacts and produces the immunogenicity, which takes care of even a higher infection. So this is actually called the threshold theory, that there is a threshold to the radiation below which it is not harmful. Earlier, it was the no threshold theory that any amount of radiation is harmful. Have I answered or clarified to some extent what the concept is?
Yeah, thank you. Thank you so much. Thank you so much, Dr. Actually, then you are saying that the cosmic radiation is beneficial to the human beings then?
Well, actually, I'm not saying this, but this is a theory which is being debated, which is being talked about. So some amount of radiation up to a particular threshold point is not harmful. It is not causing cancer. There is a threshold. It is not that any amount of radiation is always harmful. So this is a theory which is a developing theory and which has a lot of substance and a lot of merit in this. And it's the same analogy as vaccination. You inject small amounts of virus, the patient doesn't get that infection. The patient is actually developing immunity towards that particular virus. So when some radiation is given, it destroys some cells, and those cells develop, or the body, as such, the body's mechanism develops a capacity to regenerate even after a higher dose of radiation.
Thank you, Dr. Chaudhary. In fact, Dr. Chong, if you agree, I think this is a good topic which we can cover in a separate session. A whole, session can be, and I think we can invite him for a separate session about it. It's a very good topic, and in fact, all other countries can also give their views on it.
Dr. Chaturvedi, thank you very much for your little discourse on 50 millisieverts. But I do. And just to back you up, I know that the Fukushima plant in Japan originally was 50 millisievert. And after the nuclear accident happened, they raised it to 100 millisievert. So if the worker exceeds 100 millisievert exposure, then they'll pull him out. So they actually raised the threshold overnight. And the fact that 2.4 to 3 millisieverts a year is our cosmic radiation from the sky suggests that the whole human race is actually exposed to radiation throughout his life. So there may be some, rightly so, if you think about it, there may be some basis to that theory, because the whole human race is actually exposed to cosmic radiation all the time. And that may actually be a natural selection of some sort where, over millennia, the human race has evolved to cope with this cosmic radiation. Pretty much like I always tell my patients that, for example, we can metabolize alcohol because there's alcohol in nature, because of fruit fermenters, fruit and plants ferment and then we eat it, right? So it's you can understand where it's coming from. There's some form of natural selection. Yeah, I'm a physician in a practice with a radiology suite. So sometimes I do have a discussion with my patients on radiation doses. I'm very clear which scan has how many millisieverts and so on. And it's always a risk-benefit analysis, as rightly so, as rightly pointed out by the Fleshner Society. If it's a low probability, please don't do that, right? If it's a high-risk probability, high-test probability, please go ahead. So thank you very much for your most, Dr. Abhishek and Dr. Chaturvedi, for your comments and for the talk, brilliant talk. So I really did enjoy this session today. And I'm sure all my fellow friends here and colleagues and
just one question actually, yes. Because Dr. Arvind actually raised this point. This is it cumulative you can say, or cumulative? This the radiation exposure.
Oh, every year.
Yes.
Annually.
Yes.
Annual.
It is every year this much.
Yeah. Annual exposure. I was told 2.4 to 3, so around there.
Well, it actually varies from place to place. For instance, in India, in the southern state of Kerala, it is far more. So depending on the geography, your geographic location, the cosmic radiation will vary in a range. But the average is around 3 millisievert, and in some places it can be as high as 10 to 20 to 30 millisievert also, maybe in the Rocky Mountains in Colorado in the US, in the southern part of India in Kerala, there is Kerala sand itself is radioactive. So it all depends. Also, if you're surrounded by very high-rise buildings, all concrete, your radiation will be a little more than if you compare with someone who's staying in an open area in a village with not many buildings around, because all these buildings also pass on the radiation to everyone.
And there's also radon gas in the ground.
Absolutely right. And coming to the causation of cancer by radiation, well, this is a reality at high doses, and particularly as we know, the Hiroshima and Nagasaki nuclear bombs, they caused a lot of cancers subsequently in many of the population there. And at the same time, when radiation is being given as a form of therapy, the dose is 1,000 times higher than what the diagnostic radiology dosage are. And that radiation is harmful. That radiation, the body cannot cope up because it's a huge amount of radiation. It's something like, in COVID also, depending on whether it is a mild infection, if you got only few viruses, maybe you'll develop immunity. And if you have inhaled a large quantity of viruses, maybe you will develop the disease. So in radiation therapy, there is always a chance, but that takes between around 10 years to develop. Secondary malignant neoplasm, that is the new terminology, SMN, a secondary malignant neoplasm developing in the radiation field.
For the matter, even fierce chemotherapy like the lymphoma treatments like MOPP, CHOP, is well known for causing secondary neoplasm decades later.
Absolutely, yes. And so is radiation also. It is notorious to cause second malignant diseases in the radiation field somewhere, but that usually happens not earlier than 5 years, and the average is around 10 years.
Yeah, rightly so. Fascinating discussion on radiation. Haven't had this for a long time. So without much further ado, thank you very much to the two gentlemen who have given us such a lovely discussion. I think we're overrunning and into the next Zoom session coming up. So
we have cancelled that session. I've cancelled that session for the next one.
So anyway, I'd like to thank everyone who tuned in, and we don't want to overrun our time too much. So thank you very much for all who have tuned in, and thank you very much to our presenter, Dr. Abhishek Bansal, and Dr. Chaturvedi for his wonderful comments. And we look forward to seeing everybody again next week, same time, Saturday.
So we will be coming up for further new topics, and I'm also trying to bring a gynecologist, which is missing on this session, maybe talks on maternal obesity. So we will take more sessions. I thank you everyone for joining in, all the medical associations. Thank you so much.
Thank you.
हिमालय प्योरीफाइड नीम फेस वॉश, ये एक्सपर्ट कैसे?
ये क्लिनिकली प्रूवन है। इसमें है नीम और हल्दी के एंटीबैक्टीरियल गुण। ये पिंपल हटाए और स्किन बनाए एकदम हेल्दी। इसके साथ है करोड़ों लड़कियों का विश्वास और